Left to right.
Left to right?
Yeah.
All right. Joanna. And so we'll start with Joanna Hellmuth, who did the talk about pseudomedicine, and I imagine she has a few questions. Come on up, Joanna, and we'll watch the time.
Okay. So I'm just looking through the questions here, and there were a number of questions about specific supplements or other interventions. Again, there were questions about Prevagen, about turmeric, methylfolate, GABA, supplements for sleep, L-serine, some others. And I'm going to stand by that slide that we had earlier, which is that no dietary supplement has shown to prevent cognitive decline or dementia. It doesn't mean that there may not be some preliminary exciting evidence in mice, or that in healthy people there might be 32 studies that were done, and one of those 32 showed that there was some positivity. There's not enough evidence out there in the literature that I recommend any supplement for my patients for brain health unless I know they have a defined vitamin deficiency. Like if I know someone has a B12 deficiency, we know that's important for the neurons in the brain. And in that case, I think that there's an indication. But other than that, I don't personally make these recommendations because I don't see it as an evidence-based decision.
Mm-hmm. Make a comment?
Please.
So I want to make a specific comment about Prevagen, which comes from the very intelligent jellyfish. And so, you know, it's exactly the kind of compound that you would expect would improve the brain. So, you know, it's a good example of how Joanna delineated, like, how much freedom these companies have. So Prevagen was studied in Alzheimer's disease, and it went through phase 3 studies, and absolutely no efficacy whatsoever for Alzheimer's disease, period. Yet we get bombarded when I'm watching the Golden State Warriors. I you know, TiVo quickly through the Prevagen because I sort of get it, but doesn't work at all. So anyways, but they're allowed to say it helps memory, but anyways, it doesn't.
I think there's also really valid questions about whether Prevagen even gets into your brain. So from what I understand, the studies don't even show that it crosses the blood-brain barrier and gets up into the brain. So moving on, is cannabinoid efficacious? I think the question is efficacious for what? Because again, what promotes positive aging might be different for what a person with a neurodegenerative disease might need. The reality is we don't have answer to those questions because the federal government won't fund studies where scientists can study the effects of cannabinoids on the brain. So we don't really have good data one way or the other. Another question about other entities that can really evaluate the content of supplements, the kind of external consumer labs. I think that they can certainly help answer the question of safety. You know, again, if the FDA isn't monitoring these, I certainly welcome somebody else to do that. That may help answer some of the questions of safety, whether they contain other compounds, whether they actually say that they have the amount of compounds that they claim. Doesn't really address the question of efficacy and whether there's data supporting the efficacy of those. Another question here about, since more and more research on fecal transplants and blood transfusion to cure diseases is out there, what do you foresee? Even the New York Times in the last 10 days had a large article on the list of diseases that fecal transplants have cured and current fight for drug companies to take control. I've done a little bit on the media circuit since our article came out in JAMA. I've done a lot of interviews with the Washington Post, New York Times, US News and World Report, and I've learned that reporters want an interesting story. They don't necessarily want to know the story that's out there, but they want to hear something that's kind of titillating and exciting. I don't know the motivations of reporters or what gets out in the media, but I think that sometimes we can see very preliminary evidence presented as something kind of very exciting and promising. And I think that as scientists, we kind of have this irritation of doubt. We're always wondering, maybe it's not true. Maybe we need a stronger study. And so I think that we would just encourage people to kind of withhold judgment sometimes about those articles you see in Fortune magazine or other places, and really wait until we see these stronger evidence-based studies, these kind of randomized studies that Dr. Ljubenkov was talking about, that give us evidence that these work. Thank you.
We'll bring up Dr. Peter in a minute. I guess there was one thing I've been thinking as Joanna's been talking, I think it's important to talk about, for me, is the sort of sociology of the interaction between the physician and the patient when you're talking about these things. Because when these things come up, you know, and families ask us, or someone asks us, you know, should I take this or should I take that? There's a scientific view that says, you shouldn't take any of this. There just is no data, and the approach to no information is not to expose yourself to something that's dangerous or that's unknown. On the other hand, we recognize in some cases people feel very desperate and eager to do anything that they can to help themselves, especially if they're already facing a real disease. And I think sometimes even when you get in the room with one of us, we have a hard time just stating in a very cut and dried way what really we know to be true, which is in these kinds of situations you really should just stay away from all these things. And I think sometimes you have to we don't want to be naysayers or negative kinds of people, but I think it's important that there's a scientific view of this that really we have to preserve and stay with. And as disappointing it is for us to tell people, you know, there is no data, it's really the best answer. And then each person has to sort of decide for themselves, since we're all free actors and you could go buy these supplements anyway, how you want to handle the absence of information. What do you do? And we each do that in a different way. I think that's really what I wanted to say.
Can I say one more thing?
Yeah.
I just think, you know, you tend to think, well, if I get a blood test that, you know, it's really truthful, it's honest, it's straightforward. But one of the things Joanna touched on in her article is actually, it's really an epidemic in California. There are a number of laboratories that will, I think, we believe, report erroneously. So there are laboratories that, as best as we can tell, everyone who've ever gone through there has had Lyme disease. You know, this is a big problem. Similarly, you know, there are laboratories that find all sorts of nutritional deficits in someone that haven't really borne out either that they're real or that treatment of this has any effect. So basically, B12 and thyroid are the two big things that we check, and beyond that, I think a lot of this is just pure fantasy or artistry or something, but it's not, you know, all of these nutrients that you're told you're deficient in. Nobody knows that replacing this doesn't make you worse. So it's really amazingly confusing, and I think we could use a little more regulation around a lot of this. I think it's really unfair to people. Yeah.
Okay. Hey everyone, thanks for the really insightful questions. I have a few. I think these first two are actually kind of related. So the first question was, does a phase 1 trial need to be double-blind? And then another question was, what does well-tolerated or not well-tolerated mean in terms of side effects? And those are usually questions you're trying to approach in a phase 1 clinical trial. So I guess it's not necessarily always possible to run a trial that's double-blind, especially if your intervention is something like exercise. Yeah. Thank you. So you will sometimes see trial designs that are not double-blind, or you may see a portion of the clinical trial that is blinded, but a exploratory group that is open label just to see how things go, just kind of in a smaller group of patients. But generally, if you're talking about a drug that, you know, something that you take that it would be easy to manufacture a placebo for, the standard really is to do double blinding, because you really want to figure out if this person is tolerating the biological effect of that drug. And so what you're doing in most phase 1 trials is you have a certain portion of people that are on placebo, at least during a certain, sometimes you can even have a crossover design where everybody gets drug, but some people get placebo first, some people get drug first, and you cross over. And you're really just, in nitty-gritty detail, getting down to making people actually have a diary of side effects, and just really communicating their experiences throughout the trial. And we have these kinds of complicated ways to actually to make numeric scores of mild, moderate, and severe for any kind of side effect you can think of. And I mean, I'm sorry I'm being a little hand-wavy about well-tolerated versus not, but the truth is that it may actually be a little bit unique to the drug itself. If we're talking about something to treat headaches, then if a drug makes you feel a little bit nauseated, that's kind of an unacceptable balance, that you feel even a little bit lousy for something that's kind of treating a mild amount of pain. If we're talking about a clinical trial with Alzheimer's disease, a disease that can be devastating, you may think about something like ARIA and this incidence of ARIA. That inflammation that I showed before. That may be something that you're willing to think about as part of as a possible side effect for a drug. It's kind of a scary thing to think about, but it may be something that you scale, and the FDA does have these kinds of discussions when they're considering side effects. So I'm sorry if that's kind of a complicated answer to that question. Another question was, are there trials for very advanced non-fluent variant primary progressive aphasia? I'll say that the basket study is actually a phase 1. I'd have to double check with the what the explicit inclusion-exclusion criteria. My advice to anybody here is, if you know somebody with non-fluent variant primary progressive aphasia or any of the diseases that we talked about, just shoot us an email. We'd be happy to have a more in-depth conversation about whether or not a trial is right for you. And maybe we could even, if we don't have a trial that's right for you or your family member, maybe we can find one that's more appropriate at another site. We do have those types of conversations. And then there was a question, do you plan to do any clinical trials using hyperbaric oxygen therapy? And they mentioned some anecdotal evidence. The short answer is no. I mean, I think that there are a lot of, to be fair, I'm not an expert in hyperbaric oxygen therapy. I would put this in the category of something that is something that hasn't necessarily been put up against a lot of like a placebo control. So it's hard to know how to interpret. I might be wrong about that, but there are actually quite a lot of really, just kind of as a general aside, not specific to hyperbaric oxygen. You may remember on the tau slide that I'd shown, there's a lot of possible ways that we're thinking about targeting tau. And so, I mean, and all of them are really exciting. The thing is that we're talking about relatively rare diseases in some cases, and all the time we're trying to strategize how we're going to divert our resources to plan to optimize clinical trials on the best drug mechanism that we think might work. So that's kind of why we make these decisions to go for some of these biologically active interventions. The last question I think was the last question here in the stack that I got was, could you define progressive supranuclear palsy, and will the slides be online? I'm not sure. Harley would be able to tell you. I know the slides are going to be, I know that we're going to post YouTube videos of all of our talks. You could, and you can actually slow mine down, I'm sure. I was told that I spoke way too fast. Sorry about that.
You can send us the slides if you want specific slides.
I'm willing. Yeah, I'm willing to make mine available for anybody who's interested in them. And progressive supranuclear palsy, I'm sure there's a lot of folks in the audience that are actually quite familiar with this disease. By the way, whoever asked this question, I'm happy to talk to you about and give you as in-depth a response as you'd like and go into detail. But kind of broadly, it's a disease that involves a special kind of tau called 4-repeat tau. that tends to accumulate in the brain cells and in neurons and these supportive cells called glia that kind of support neurons. Now, the most kind of typically recognized version of it makes it progressively harder and harder for a person to move their eyes, and it makes it really, really hard for the person to stay balanced and they fall down a lot. But it's actually a very, very diverse disease, and it can have a lot of other clinical presentations. And that's why, whoever's really curious about this, I'm happy to kind of talk it over. And I'm not sure if the person is worried about a family member possibly having it, or if they'd like to just know more about the disease for themselves. But I'm happy to answer that question later on. Thank you very much.
Caitlin's coming up in a sec, but there was one more thing. I remember what I was going to say before, but I think it's really important to know, a lot of our worries about recommending something that hasn't been really assessed in the scientific ways that we talk about is because what we find is when they are assessed, sometimes they don't work, and that's one thing, but sometimes they actually cause harm. And my two favorite examples are vitamin E and estrogen replacement after menopause. So for many years, we thought we had pretty good evidence from observational kinds of studies that taking estrogen after menopause was healthy. We thought it was good for your brain and good for your bones and good for your heart. And a lot of people recommended it. And it's a natural substance, clearly. So it sounded pretty good. And then finally, the most rigorous approaches were taken to it, where they kind of randomized who was on it and who wasn't, and followed the people for many years. And it turns out just about every one of those facts that we thought we knew at the time turned out to be wrong. And I'm sure many of you know this is not a standard recommendation anymore as postmenopausal estrogen, unless you have postmenopausal symptoms that maybe can't be addressed in another way, or there are other reasons to do it. But it's a great example. So the thing is, if we do the experiment in our head for all these supplements, if they were really put to the test, I'm sure some of them would come up not just ineffective, but dangerous or worse than nothing. And that's why, our sort of approach is always, well, we have to be really cautious, because, a lot of a great approach to life is this, oh, it couldn't hurt, right? But sometimes it could. Oh, yeah, sorry. Vitamin E in large doses. So, small doses of vitamin E like you might find in a multivitamin, no problem. But for a while, we were recommending 2,000 units of vitamin E, which is a fairly large dose, based on some small, pretty good studies that suggested that it was effective for Alzheimer's disease. But then we looked at larger studies and put the information together, and it suggested that large doses of vitamin E like that are not so healthy, and that it may promote earlier death and things like that. So we no longer recommend large doses of vitamin E, but there's nothing wrong with small doses, 80 units, 100 units, like you would see in a multivitamin. Thank you. You're welcome. Sorry. Don't be...
All right. Thank you all for your questions. I have, I think, more questions than I can answer, so I'm going to try and group them thematically. So I apologize ahead of time if I don't get fully to your question or don't fully answer your question. I'll be hanging out afterwards. I'm happy to answer anything. But one question that came up was, what type of exercise should I be doing? Have there been any studies that have compared different types of exercise against each other for brain health? And so the data, some of the data that I showed you, there was this meta-analysis, which is a fancy way of saying that they looked at a bunch of the studies that have been published and they analyzed them again of randomized clinical trials of exercise. And basically the conclusion from that study was that kind of any type of exercise, again, as long as it's vigorous and sort of a good period, about 45 minutes for each session, was good for cognition. So any movement counts is what I tell everyone. But there has been particular evidence, I think, for aerobic exercise to be maybe even a little bit more potent for the brain. So there have been some studies comparing aerobic exercise to more low intensity exercises like toning and stretching that have shown, maybe some even potential benefits to aerobic activity. And maybe that speaks to promoting, that vascular system, the health of our brain cells, as well as clearance of the bad proteins in our brains. So I think that we can think about getting your heart rate up to the point where you can't talk when you're exercising is probably good for you. And then the other questions were a little bit about cognitive activity interventions, and specifically someone was asking about posit science. This is one of the brain training programs available that you can pay for, and the data that I showed on the active study, who followed participants for 10 years and showed that those who had trained also had better abilities 10 years later, they did use the posit science program. Again, I think this program is fine, and it shows you can learn a skill, you can maintain that skill, and I think if you enjoy it, we don't know of any harmful effects from these cognitive training programs, but they do cost money and they take time, and they could take time away from being in front of a computer versus hanging out with family and engaging in both cognitively and socially active types of activities. So I think it's really individual, and what you find enjoying and challenging and novel is up to you. So I'm not going to specifically recommend one program over another, but I think posit science is just fine if that's something that you want to try out. And then another question around social interactions. If you're not a very social person, you'd prefer to read, should I be doing social interactions? Again, I think we should all be doing things that we like to do, but I also think we should be doing things that challenge us a little bit. There are data that show among the leisure activities, there might be something particularly helpful about social interactions, around being around people. It seems to be particularly good for our brains. It doesn't mean that you have to go to a big party and stand up in front of everyone and do karaoke, but I think this could take whatever form is good for you. So hanging out with your grandkid, with a loved one, with a family member. I do think there might be something particularly sort of uniquely helpful for your brain around being around people. So that's a great question, but not very well studied, so something we're really interested in. Another question asked, why are there so few people of color here and in our studies? And I think this is a really on-point question, so I just want to make sure I address it. This is something we're really interested here in the MAC. We're pursuing a lot of outreach events and trying to recruit as diverse aging adults as we can, because we know that brains age differently. They might age differently depending on someone's race or ethnicity or socioeconomic or educational factors, and we are so interested in this. And so if you have any suggestions, we've really integrated it into the Mission and 30th Street and Oakland, other retirement centers, and this is a huge push, especially in the next couple of years of our last cycles of big center grants. So if you have other suggestions of ways that we can get creative around this, we would love to hear it, but definitely something we acknowledge and would like to improve moving forward. Okay, more questions around, is brain atrophy normal as we get older? This is a great question. So I showed you sort of that graph of what happens to cognition over age development. I could show you a similar graph at a group level of what happens to the brain volume as we get older too. So yeah, our brains get bigger when we're little, and then we do see atrophy, loss of gray matter tissue as we get older. And the question, sort of other questions were, how can you tell when this is bad? So at a group level, there is loss of tissue as we get older. When is this bad? Honestly, when it becomes clinically important. So you could have, one neuron hanging on, but you're doing really well in everyday life. You're doing everything you want to be doing, and that's all that matters. And in fact, we do see a lot of these discrepancies. We see really unhealthy looking brains, but healthy looking people, and vice versa. So this is kind of a really interesting problem that we think about a lot in our healthy aging team. And so when it's becoming a problem, or when you're thinking about it, when you're concerned about it, please contact us. Come into our clinic. Even if you're not sure, maybe this isn't really a problem, but I'd like to get it checked out. We would love to see you. You can do a baseline evaluation to just get a brain health check, see where you're at. Then we can follow you in 2 years, 3 years, and just make sure everything's going okay. Provide any recommendations to support your brain. So if you're concerned, please get in contact with our clinic. We're happy to see you, even if you're not sure. And then a question around, can you diagnose Alzheimer's disease before autopsy? So I think you've all been taught really well here that we can't diagnose neurodegenerative diseases really until someone passes away, and then we look at the brain in the microscope. This is still the case. That is the gold standard. So when we're showing you these really cool brain images of the different proteins and molecules in the brain, These are novel research tools that we use to image these proteins. They're new, they're up and coming. We're still trying to figure out exactly what they mean. And so in life, we can sort of put that together with how you're presenting to us clinically, the brain atrophy we see on the brain MRI, and we try and put that together to give a prediction of what we think at autopsy might be going on. But we can never be 100% sure until someone passes away. So it's a good question. And then a bunch of questions about diet. So one question about Dean Ornish's study going on here that recommends sort of a low-fat diet. So Dean Ornish is a collaborator here. We have some lifestyle intervention studies going on with him. This is more of a multifaceted lifestyle intervention, looking at diet and exercise and cognitive stimulation and social support, and trying to promote better brain functioning in people with mild Alzheimer's disease. And so he takes more of a low-fat diet approach. And is this different than the Mediterranean diet? I think the verdict is still out there for diet, though the Mediterranean diet seems to show better brain outcomes. There's also data that show basically high glycemic diets are also associated with more amyloid aggregation in the brain. So diets that are higher fat, higher glycemic, which the Mediterranean diet kind of is the opposite of mostly, seem to be associated with worse Alzheimer's-related outcomes. So I think low fat is also another way to think about that and could be helpful. So we'll see. We'll let you know what we find out from that study. Let's see. Another question about treating high cholesterol. So if I'm within normal limits, should I be treating my cholesterol if it's sort of high? This is a great question. So I talked a lot about the vascular system and how this is important to the brain. And I think we should definitely, aggressively treat any values of high blood pressure or high cholesterol that are outside of normal to treat the vascular system. And we know what's good for the vascular system is good for the brain. In terms of treating the brain with these types of medications, we're not really sure. I don't think the data are there yet to say that you should be on a cholesterol lowering medication at this point if you haven't reached that clinical threshold. So I'd encourage you to get in touch with your doctors and just make sure that your vascular health is really good. And that's really the best thing to do for your brain at this point. I'm also a PhD, so happy to take any input from the MDs up here. And then, will the slides be available? So yes, and if you're interested in our studies, how do you contact us? Please feel free to touch base with me at the end. You can email myself or Nina or anyone on the Healthy Aging team. You can email Joel directly and get in touch with us for any questions or participation in the studies. And they're all on the website.
There's also a sign-up sheet outside.
Perfect.
And if you just search UCSF Memory Aging Center, you'll probably end up with my number. So feel free to call and we'll get you to the right place.
Great. All right, I think I've taken a lot of time, so I'm going to leave it at that. Thank you all.
All right, hi again. Thanks for all your questions and your interest in genetics. I just have to say I'm not going to be able to offer an individual risk assessment to people asking specifically about their own family history, but I'm happy to be available afterwards if you have individual questions. So there were just a few here, and one question was about which tests give health risks and predictions to suggest to medical providers to order. So I'm gathering that this question is there a list of genes that we would suggest that you write down and then go to your doctor and ask them, please help me order this to guide my health? So I'd say that we don't have a kind of go-to list of certain genes. Most providers who are thinking about, is there an appropriate genetic test for my patient, are thinking about your clinical history. So are there symptoms that you're facing? What are those symptoms? Do they comprise a larger syndrome? What is your family history? Is there reason to suspect a clear single gene cause of your symptoms? That's usually how genetic testing is approached in the clinical setting. So, and keep in mind that predictive genetic tests, they're often primarily helpful for families who already know that they come from a family with a single gene condition. And usually, not always, there are exceptions, disease, your family history can be very telling as to whether or not it's likely you have a single gene cause of your symptoms. There was another question about what are other genes to consider besides ApoE, maybe something that I could look up on my own in my raw data. So this is kind of a bit of a challenging question. There are a number of genes that we know of that are also implicated in increasing risk for Alzheimer's disease, not just ApoE. You may have heard some of them at previous research events, TREM2 and others, and genes involved in in inflammation. And I think the bigger issue is that companies like 23andMe have their chip, and the data points that they release in the raw data, it doesn't encompass every single data point in your genome, in all of your genetic material. And so they have, the biggest company that offers this has about 600,000 data points about you, but that could be scattered throughout your genome. It could, and it's, because it's proprietary, it's hard to know if of those 600,000, they have information about your particular risk result with regards to a gene other than ApoE. So it's a little multifaceted there. I think this promise of polygenic risk scores, it's coming, if not in an early iteration here and available. I think it's going to be, it's also a little challenging to know how much does any one gene contribute to a person's risk. How do you weight each risk, individual risk conferred by a single gene? And I think that would be difficult to do without the work of people like Dr. Rahul Desikan and Jen Yokoyama. So I think my advice would be to wait a little bit longer until we have a better sense of how best to weight out all the potential genetic contributions to Alzheimer's disease. And then there was another question about are there genetic tests for generalized anxiety disorder or depression? So there are no specific tests, genetic tests that you can get for depression or anxiety. We know that there is a genetic contribution to each of these conditions, but even if you read about a gene that was published to be associated with either of these conditions, again, these are usually reports that describe associations, right? In a group of people who suffer from major depression, they are found to have this particular gene version. But if that that particular gene is directly related or indirectly related in a person's depression is difficult to parse out. And so I wouldn't recommend any test like that. And I don't think that's even available. And then lastly, there was a question about epigenetics. Is that being studied? So this epigenetics describes the field of genetics looking at changes not in the actual DNA code, but rather in expression, the levels of a certain gene that you might find either temporally, right, in throughout the life stages, or in different tissues of the body. And that is actively being researched. We have a gene scientist in our own group, Dr. Jen Yokoyama, who's very interested in this particular field of genetics. The epigenetics has not yet entered the direct-to-test consumer market. So, of course, all remains to be seen. And yeah, I think that covers my questions. Thank you.
All right, so I think we're running short on time, so I'll be try and be brief with my response. And the main question that I got was related to tips for promoting brain health earlier in life, so in childhood and also in the teenage years, and perhaps how that might relate to brain health outcomes later in life. And I have to admit, as an aging researcher, I've been guilty of often focusing my research more on individuals who are in later life stages, older adults. And I think that as a field, we really have to do a much better job of sort of taking a broader perspective and thinking about how all these experiences across the entire lifespan, beginning in childhood, can influence trajectories later in life. So, I'm not intimately familiar with the literature on what factors promote brain health earlier in the lifespan, like in childhood, but I think what I will say is the brain takes a long time to develop, and you see changes in the brain and ongoing development in certain brain regions like the prefrontal cortex, and also the white matter of the brain still forming into folks' 20s, so it takes a really long time. And so I think just knowing that, as the brain is continuing to develop, it's important to make sure that it's exposed to the most healthy environment as possible. And so I would speculate that some of the same things that we've talked about that promote brain health in late life are also really important in childhood. So things like nutrition and physical activity, avoiding head injury, being really intellectually and cognitively engaged and stimulated, socially engaged, sleeping well, having good access to health care, and so forth. And I know as part of the healthy aging team, we are trying to take this broader perspective and asking about experiences earlier in the lifespan and seeing if that correlates with brain health outcomes in later life. So, for example, inquiring about history of repetitive head injury and maybe traumatic or stressful experiences in life, and seeing if we can link those to biological measures that we know relate to brain health, like measures of inflammation in the blood. So anyways, great question, and hopefully with time we'll be able to answer it better with more research.
I don't really understand why, but my questions are much less technical. The first one isn't a question, it's a statement. This person wrote, "Kornbluth for president. Donate now."
Did you write that one?
I did not write that one, and my mother isn't here, so I don't know who wrote that one, but if you think things are bad now, Kornbluth for president's a really bad idea. Executive functioning is something you want from your president. But if you do donate, make your checks out to cash. Great question. Can I share Josh Kornbluth's video on Facebook? Yes, please do. Please share it and view it on multiple computers so you seem like more people. It's actually, they're both really popular. That's what we're here for. We want to spread this word. So yeah, on Facebook and on YouTube, you can go to Citizen Brain or the Empathy Circuit for the first one, video, or Age Without Ageism, or just even Google my name and you'll get there. Please, yes, do share. And lastly, kindly ID the location of blue zones that summarize any common characteristics of these zones. So because I'm embedded in this academic setting, I have access to a search engine called Google, and I took the opportunity of looking it up since I didn't know the answer, or you can watch the video and just freeze it at that map. And the places are, these are blue zones where people tend to live longer, according to this idea. Okinawa, Japan, Sardinia, Italy, Nicoyan, if I'm saying that right, the Nicoyan Peninsula in Costa Rica, Ikaria in Greece, and they're very specific here, Seventh-day Adventists in Loma Linda, California. So apparently, if you just go to Loma Linda, just hang out, but you just have your own regular beliefs, you're screwed. You really have to become a Seventh-day Adventist, and I'm sure they've done the controlled research about this. So, and I will just say in closing, I don't, this isn't scientific, but my beloved grandfather, my maternal grandfather, Julius Selden, lived to 103, and he was very, very on top of things and flirtatious with my girlfriend and everything until the very end, and I'm not recommending this, but in the old country, in the shtetl, back it wasn't a blue zone, it was a Jew zone, actually. Very circumscribed. So, but my grandpa was, as a youth in the shtetl, in the Jewish ghetto, he was a pickpocket. And so my thinking is that there was a lot of aerobic benefit to that. And maybe even pickpocketing later in life, after 50, could be helpful, but we need more study.
I just want to mention the closed caption and the translation. The closed yeah. So thanks, Josh. Someone asked earlier about closed captioning, and actually we didn't have it here, but Josh's videos, as they are on YouTube, do have closed captioning as well as translation into like 4 other languages. So as you recommend that, be aware that we have some of those thought through. He has. And Bruce, you're the last one? Yeah. Bruce is going to wrap it up.
I think I was out of my mind to go from right to left, to left to right, actually. And I have all of the questions that nobody else wanted to answer. So anyways, okay, it's a really good question, and I'm going to give a slightly longer answer here. Do MDs and PhDs in neurology, psychology, social work, etc., anticipate and support patient access to right to obtain euthanasia in advance of patient competence? So it's a really complicated question. It's an important one. I must say I have learned so much in this space over the last decade. We had an event on death and dying, and I realized that I had never really systematically thought about this, or never gotten one lecture in medical school or any part of my training about how to deal with this. We're very different than we were a few years ago. So one of our psychologists, Kate Poseen, has set up something called Care Ecosystem, where the day that a patient comes in to see us, we start thinking with them and with their family about what they might want if they had advanced disease, what sort of interventions they would like and wouldn't. And I mean, that's clearly the point at which we need to make these decisions. And all of you need advanced directives, and you need to guide the team that will look after you in later stages of life, and we all have different philosophies, and we really want to honor your philosophy. But if we see you in an advanced stage without any directives, I think it is much more difficult. The other things that I think are happening in our program and across the United States and Europe, well, everywhere, is palliative care teams. So I think we institute this, in the middle stages of a degenerative disease, where you have a team of people that are thinking with you about your loved one, and what is too much, what is too little, and so these are things that we think about. And then finally, too little use of hospice. So hospice is everyone in this state is eligible for hospice in later stages of degenerative disease. You bring in a team of people who know a lot about death and dying, and it's never easy. I've never been involved with a death that wasn't heart-wrenching, with all sorts of unusual twists and turns, and this is without a doubt one of the hardest things any of us ever go through with a loved one. But I think having a team of people to think with you about what might be the right answer, the wrong answer — there are no right or wrong answers — but I think this is really critically important. So this is the biggest change in our program, I think, over the last 5 years, is that we are incorporating palliative care. Christine Ritchie and George Nassan have brought a program like that into us. Okay. Has there been any progress in the theory that Alzheimer's and Parkinson's are related? It's something I'm really interested in. How Rosen leads a program with our movement disorders, where we think about the intersection of the two. And I must say, more than I would ever have expected, thinking of two so-called distinctive diseases, I will see someone in my Friday clinic who comes in and has evidence of the onset of Parkinson's and an Alzheimer type disorder together. And I think it's way more common than we might have expected. And I believe if we could really lower the prevalence of one of these disorders, we would lower the prevalence of the other. How they interact, why that happens, is really unknown. I think the best theory right now is that the bad proteins that aggregate with Alzheimer's trigger the Parkinson proteins as well. This is a very important area that we don't understand very well. Okay, this one, yeah, I don't think I understand that. Okay, so a lot of questions about infectious cause for Alzheimer's. It's been in the news a lot. Mind you, since I started my fellowship 35 years ago, every 3-4 months there is something really compelling that is causing Alzheimer's disease or curing Alzheimer's disease that appears in print. And then, you know, we take 2 or 3 years to study this and find out, well, maybe that wasn't true. And sadly, that's been the story of all of these potential causes and treatments. I think the bacteria story is really interesting. And I think the epidemiology is reasonably good, that if you have gingivitis, poor gum care, that this is probably a risk factor for developing neurodegenerative disease. Is it a huge risk factor? I don't think so. I think I put it in the category of diabetes or high blood pressure or many of the things we've talked about. It's a risk factor. Does that mean that we'll have a treatment that'll be based on lowering bacteria? Probably not. And, you know, I think all the things we're learning about the microbiome is that this is a really complicated thing. And every time we take an antibiotic, we change the microbiome that we have, maybe sometimes for the worse. So I think this is a correlation, not a causation yet. Maybe it's like Kaitlin thinks about, that maybe just having inflamed gums increases inflammation and increases peripheral inflammation that has effect on the brain. Just don't yet know why this correlation occurs. But that, I'm sorry, that's a vague answer, but I think that's where the state of the art is right now. Okay, one more question, and it was about, what about this epidemic, 3 times the increase in dementia in low and middle income countries? Why is that happening? We think it's 2 factors. One is that, just as the question asks, it's because in these low and middle income countries, India would be an example, suddenly people are living into their 70s, 80s, 90s. So they may have had very low prevalence of aging in previous decades. Now, and then the next 30 years, many more people will live into the age at risk. That's one of the big reasons. The other reason is this 30% of preventable risk factors that are not addressed in low-income countries. We've learned this a lot through our Global Brain Health Institute. So, if you have a low education, you are much more likely to develop a degenerative disease. There's no doubt about it. And when you get one, you will get symptoms with less atrophy than someone who has high education. So you just don't tolerate these proteins at all if you have low education. So these factors, lack of treatment of hypertension, all these other preventable things are also present in low and middle income countries. And, I don't have to say countries, because you can point, just down the road a little bit, and we have communities in this city where people are at increased risk for this because of lack of access to health care. So I think this is something that's unbelievably important as we think about the future. And putting a little money in up front is going to save the society billions of dollars. So this is cost effective, making sure that there are healthy clinics for women who are pregnant, for children who are obese. These are things that society invests in, and it pays off hugely with a wise group of elders who can direct the next generations. And many of us are in that category in this room. So that's all.